In this session, I will be discussing chronic myeloid leukemia, that is CML. So let's start CML. Okay. So before starting CML, I would like to advise you that you should compare the 4 types of leukemias like this in a tabulated manner. So the 4 leukemias which will be discussed in separate videos here, that will be CML, AML, ALL and CLL. So these 2 are myeloid leukemias, these 2 are lymphoid leukemias. So you should be able to compare them among following headings: the definition of each of them, age of presentation of each of them, the pathogenesis, the exact mutation you should be knowing of each of them, the classification for each of them, the FAB classification, WHO classification, all classification, the clinical features, lab diagnosis, treatment and prognosis, all the prognostic factors. In your competitive exam, your maximum questions will be from either classification or pathogenesis or prognostic factors. So if you compare them in this manner, it will be easy for you to retain the findings in each of them. Okay, so let's start with CML, that is chronic myeloid leukemia, the first leukemia I am discussing here. So what is the introduction? What is the definition? It's a leukemia. The chronic myeloid leukemia is an acquired disease of hematopoietic stem cell that is characterized by, there are 4 findings. So let me enumerate the 4 findings. It's leukocytosis with granulocytic immaturities, right? So the WBC count in the blood increased, right? But all the WBCs are immature. The granulocytes are immature, they are not mature, right? The second is the basophilia. The basophils are also increased. The third is the splenomegaly. The spleen is enlarged. And fourth is the presence of Philadelphia chromosome. I will be explaining you what is Philadelphia chromosome. So in any patients, if these 4 findings are there, you can label the patient as CML. So you should learn the definition of CML. The age of presentation is relatively little bit towards the old age. It's after 50 years usually. Coming on the pathogenesis. The pathogenesis is very interesting. In the pathogenesis, there is 922 translocation. You can also call 922 translocation as ABL-BCR translocation. So because of this translocation, the chromosome is Philadelphia chromosome. Now what do you mean by that? Now we know that in human cell, this is a human cell. Inside the human cell, this is the nucleus. Right. Now these are the WBC precursors, just suppose, right, the hematopoietic stem cell and the precursors of the WBC. So inside the nucleus, the DNA is present. So in the nucleus, 46 chromosomes are present. You can say either 46 chromosomes or you can say 23 pairs. This is pair number 1, pair number 2, pair number 3, pair number 4, likewise till 23 pairs. So I am interested in pair number 9 and pair number 22. Right. So what is happening on pair number 9 and 22? Let me show you. So normally on chromosome number 9, a gene is present. The name of the gene is ABL gene. It's normal. It's in all normal human beings. And on chromosome number 2, a gene is present. It's known as BCR gene. Right. It is normal finding. So here you can see this is, let me draw. This is chromosome number 9, the 2 copies of chromosome number 9, and these are the 2 copies of chromosome number 22. You all can see it. On chromosome number 9, as I have told you, normally in all human beings ABL gene is present, so here is the ABL gene. And on chromosome number 22, BCR gene is present. So it's normal to have ABL gene on chromosome 9 and BCR gene on chromosome 22. It's normal. But during translocation, so here the mutation is the translocation. So a portion of 9 is given to 22. In exchange of it, a portion of 22 is given to 9. So in this exchange, when 9 is giving one portion to 22, it's the ABL gene which will be transferred to the 22. On 22, BCR was already present. Right, and now ABL is also coming due to the translocation. So because of which a new fusion or hybrid gene is formed. What it is known as? Either you say it fusion gene or you say it hybrid gene. So either fusion or hybrid gene is formed, right? And that will cause an abnormal tyrosine kinase activity, because of which there is uncontrolled mitosis in the cell, and that can result in leukemia, right? The blast will undergo uncontrolled mitosis. So they will be spilled over into the blood, resulting in leukemia. This is the pathogenesis. Now when in this translocation, chromosome 9, the ABL gene is transferred to the chromosome number 22. In the exchange of it, chromosome number 22 giving a portion of 8 to 9 which doesn't have any important gene. So this is known as translocation. So can you tell me what is happening here? Normally ABL gene is present on chromosome number 9. Now this ABL gene is translocated to chromosome number 22. On 22 already BCR was present. So this ABL fuses with the BCR. Because of this fusion, hybrid gene is formed. So that's why chromosome 22, the hybrid is formed on 22, not on 9. So chromosome 22 is known as Philadelphia chromosome. So what is Philadelphia chromosome? It's very important MCQ. It's the chromosome number 22 on which the fusion or the hybrid gene is formed. So it is a 210 kilodalton fusion gene, right? Now it will result in abnormal tyrosine kinase activity, because of which uncontrolled mitosis takes place and it results in CML. So this is the complete pathogenesis of the CML. I hope you got it. You can see the chromosome 9 ABL gene, the chromosome 22 BCR gene. During translocation, the 9 ABL is transferred to the 22. On 22, fusion takes place, hybrid takes place, and a new gene is formed that results in uncontrolled mitosis. So you got it, I guess. Now coming on the phases of the CML. In the CML, there are 3 phases: the chronic phase, the accelerated phase, and the blast phase. These are the 3 phases of the CML. How to define? You can learn like CAB. The chronic, the accelerated, the blast. In the chronic phase, the blast percentage in the blood is less than 10%. In accelerated phase, the blast percentage is 10 to 19%. And in blast phase, it's more than 20. You can see less than 10, 10 to 19, more than 20. So based on the percentage of blast present in the blood, we can say the phase of the CML. We can say the phase of the CML. Coming on the clinical features. Now inside the bone marrow, RBCs, platelet, WBCs are all formed. But here the precursors of the WBC, that is the immature WBCs and the blast, they are going uncontrolled mitosis. So they will replace the RBC precursors also, and they will replace the platelet precursors also. So RBC is less formed. Patient have anemia. So anemia patient will complain of pallor, lethargy, dyspnea, right? In the same way, platelets will not formed or less formed. It results in bleeding disorders, thrombocytopenia. So spontaneous bruise, pateki, bleeding from the gums, other sides, that will happen. And here WBC are in axis. I agree. They are in axis, but all of them are immature. They are non-functional, they are immature. So this patient is prone to infection. So technically the patient is like pancytopenia, but here RBC, WBC are decreasing, but WBC count is increasing. RBC and platelet is decreasing. You got it? So this is the clinical features. The clinical features of hypermetabolism also present, like weight loss, lassitude, anorexia, and night sweats. Along with it, splenomegaly is massive. Along with it, the splenomegaly is massive. Now coming on the lab diagnosis. Coming on the lab diagnosis, we can classify the lab diagnosis under following headings: the blood picture, the bone marrow picture, the cytogenetics, the cytochemistry, and others. In blood picture, we have to see patient have anemia, thrombocytopenia, so RBC are less, the platelet are less, but WBC count increased. So what is the normal WBC range? The normal WBC count is 4,000 to 11,000 per cubic mm. Here WBC will be nearly 2 lakh. Instead of 11,000, it is in lakhs. It is usually 2 lakh or more. So most of them are neutrophils only. The precursor of the neutrophils, that is promyelocyte, myelocyte, metamyelocyte, and band forms. Along with it, the neutrophils, basophils, and eosinophils are also there. So that is the blood picture. Here you can see the blood picture. We can see this is a eosinophil here. You can see this is a basophil here. Apart from which you can see abundant of cells, all of them are precursors of the neutrophils. They can be band form, promyelocyte, myelocyte, metamyelocyte, they can be all. So this is the blood picture, a beautiful blood picture. Now they can come in the form of the image based question in your exam. In this image, you can see the various types of the cells. Now this is known as garden party appearance. It's garden party appearance. Why it is known as garden party? Because in a garden party, everyone is in different dress. It's not school that everyone should have a uniform. Everyone have a different dress. So here all the WBCs are looking like differently. That's why this is the simile we see, right? So you can see, we can see here eosinophils, basophils, eosinophils, neutrophils, the precursors, promyelocyte, myelocyte, metamyelocyte, band form. So this is CML. Right, I will be teaching you the peripheral smear of all. Currently, I have covered the peripheral smear of the CML, in which we are seeing all the granular precursors, the immature granular precursors. Coming on the bone marrow findings. In the bone marrow finding, there is hypercellularity number 1. There is increased myeloid erythroid ratio. Now, ME ratio, the M is increased this time. E is not increasing, the numerator is increasing, so the ratio is increased. Erythropoiesis is reduced, megakaryopoiesis is normal or reduced. So that is the bone marrow. Now cytogenetics. In cytogenetics, you will typically found Philadelphia chromosome. You will found Philadelphia chromosome in 95% of the cases. So what is Philadelphia chromosome? It's chromosome number 22 on which the fusion or the hybrid gene is formed. That is cytogenetics. The next is the cytochemistry. In cytochemistry, we will do a stain which is known as NAP, neutrophil alkaline phosphatase. Either you say NAP, neutrophil alkaline phosphatase, or you say LAP, it's leukocyte alkaline phosphatase. So basically what is happening now, you can see normally the neutrophil alkaline phosphatase inside the neutrophil is present, and if you stain it, you can be able to highlight all these cells on the peripheral smear. But in a case of CML, when immature the granular precursors are present, they do not have NAP or LAP inside them. So this stain, the scores are reduced. So here basically the scores are reduced. So here you can see the scores are reduced. Here it is written. So the NAP or LAP scores are reduced. You have to learn that. In the others, you can find there is hyperuricemia or gout. So we are done with the lab diagnosis. What is the treatment? The treatment, you can give the supportive treatment, like if the patient is having anemia, give blood transfusion. If the patient is having thrombocytopenia or bleeding, you can give platelet concentrate, right? You can give regular platelet concentrate also. The main drug here is imatinib. Imatinib is going to be the main drug here. It is a targeted drug. It will cause apoptosis of all those cells which contains the hybrid gene. The ABL, BCR hybrid genes, they undergo apoptosis because of the imatinib. And the final and last option for treatment is stem cell transplant or bone marrow transplant if the HLA matched donor is available. Now coming on the prognosis. In the prognosis, there are two types of index, the Sokal index and the Hasford index. In the Sokal index, 5 criteria are there: platelet, age, spleen size, blast and cytogenetics. In the Hasford also we are having age, which was a common feature here. Here we are having basophil and eosophil, circulating blast, platelet count and spleen size, based on which we can do the prognosis of the CML. So that's all about CML. I hope you learned the topic well. So we will be doing some MCQs based on this. The first question is in front of you. Can you tell me ABL BCR hybrid gene is present in? It is present where? So of course it's present in CML. We have just seen ABL BCR. ABL is present on chromosome 9, BCR is present on 22. So that is ABL BCR hybrid gene which is formed on chromosome 22. It is known as Philadelphia chromosome, right? The next question is in front of you. Take the clues. So there is a 60-year-old man. Number 1, the age is a clue. Presented with fatigue, that is anemia, weight loss and heaviness of the left chondrium 6 months back. Hemogram mein hemoglobin is little bit less. TLC, total leukocyte count, it's 5 lakh. Normally it's 4,000 to 11,000, but here it's 5 lakh, indicating it's a clear-cut case of leukemia. The platelet count is in normal range still. The patient have DIC, DLC, that is differential WBC count. So in the differential WBC count, we can find promyelocyte, myelocyte, metamyelocyte, all of them. So definitely the diagnosis is CML without any doubt. Now what is the pathogenesis of the CML? The pathogenesis here is translocation 922, right? So the correct answer here is 922. So that's all about CML. I hope you learned and enjoyed the topic. Thank you.